I think translation in taking discovery research findings to application in health, I have two translational blocks. The first one is from bench to bedside, which is research discovery ultimately to have a product, a human application. Second is bedside to population, which is taking that product and ultimately being able to apply to community to be adopted and to have a health impact.
We are assuming that the problem in translation is that we have these great tools, but they're not being translated out into healthcare delivery. And in fact, the problem may be that we don't understand the problem. Translation goes in both directions. And I think that we have the risk of creating absolutely marvelous tools to solve problems that we don't have.
How do we take a new promising technology and get it into practice? The question is, how much does it cost and how much benefit does it provide? And that's, you know, we didn't discuss that of the 10,000 new potentially useful discoveries that didn't make their way into clinical practice. Would they have been appropriate from a cost-benefit perspective? And that cost-benefit perspective is going to vary from the financing and economy and the wealth of the culture in which you're operating.
What do we need to make it happen? Well, first of all, we have to show the step which is from efficacy to effectiveness, which needs randomized controlled clinical trials. And they play a major role in maintaining quality in our health service, just the participation and also disseminating good ideas. But it's back to the kind of what I nickname the McMaster syndrome. So it worked in the randomized clinical trial. Will it work in the dirty world of reality? And that's not just about cost effectiveness, though we will have put in a health economic assessment, and we will have our National Institute of Clinical Excellence opining on whether the NHS should use it. It's about the culture of people.
How do you create the delivery systems and the infrastructures that accept these new discoveries and incorporate them into the most efficient and effective and broad-based acceptance? And we have very little, across the world really, we have very little in the way of expenditures to try and understand that. Basically, we use the transom model. Discovery, commercialize, throw it over the transom and let the delivery system figure out what the hell to do with very little investment in R&D.
The subtitle of today's session was how to translate today's science into tomorrow's healthcare. I would ask then that, how successful have we been at translating yesterday's best science into today's healthcare? And, it's true that I think physician choices in therapy and in diagnostics is often driven by industry. Not that there's anything wrong with that, but, it does sometimes lead physicians to base their choice of drug upon who was the last drug rep who walked through the clinic door. And what we've tried to do in Singapore is, again, taking a leaf out of what many professional groups in the United States have done, is to come up with clinical practice guidelines based on consensus statements from expert groups, and then apply that wonderful word, incentives, to get practitioners to adopt these.
The object of this session is to find the best way to fill the gap between upstream science discovery and application in clinical practice, right? So sometimes we should ask ourselves, what should be improved in clinical care in terms of science application, in terms of new technology, in terms of new surgery? So simultaneously with the top-down approach to realize scientific discovery to make a new drug or new molecule, we should ask we should approach it from bottom up, from the front line of patient care area.
We're in our 5th year now of deploying the Toyota production system as our management method for the entire health system. So not just primary care or critical care or cancer, but the entire organization. So this is both top down in that the leadership says this is how we're going to do our work, but bottom up in that we design processes for the people on the front lines, both doctors, nurses, and staff at all levels, to redesign the work. And what we're finding is that we can take tremendous amount of waste out of the system, shorten the lead time, and then have a lean system that's ready for the new innovation, that's ready for the new technology, that it's layered on an already existing waste-free system, and that you know just where it's going to fit. It's almost like plug and play.